So I was going to give people about 5 minutes or so before they enroll. Let me put my camera on, but I think we've got such a decent number already. Delighted to see that this is such a popular topic. Lovely to see some of you introducing yourselves in the chat. My name is Jantina de Vries. I am based at the University of Cape Town and work in bioethics, and I'm a member of the Global Health Bioethics Forum. So thank you for joining our meeting today, which focuses on a broad question about what it means to involve people with mental health conditions in research ethically. The focus of this webinar is specifically on the practical challenges of doing research with and on people who have mental health conditions. And that might be empirical ethics research. So hopefully some of us on this call have actually done research that looks at ethical concepts, but involves people with mental health conditions in exploring what it means to do research ethically. Judging by the extraordinary number of registrants today, we had over 400 people register. This is an important topic for all of you. Now, you will know that, hopefully, that this is the second of 5 seminars organized by the GFBR on the broad theme of ethical issues arising in research with people with mental health conditions. This was the theme of the 2020 GFBR, which had to be initially cancelled and then postponed, and now it's going to happen later this year in a hybrid format. But we decided to take some elements from the program into a series of webinars. These webinars will run until the end of November, every 2 weeks. And if this is a topic that you work in, then please check out the GFBR website to look at when and what other seminars are taking place. The meeting will be recorded, as Adam said at the start of the chat, and a recording will be available online in about 2 weeks' time. So if you miss parts of it, or you have to leave early, be sure to check that out later. We are joined today by 3 panelists who I will introduce shortly. The seminar is scheduled for about 90 minutes, so we can have a thorough discussion, but we can, of course, end the discussion sooner if it comes to a natural close. Each of our 3 panelists will start shortly with a short opening statement of a few minutes, sharing with us some of their views about the ethical challenges of involving people with mental health conditions in research. I will then mediate a short discussion based on some of our previous discussions with the panelists, but also some of the questions that you have raised during your registration. After that, we'll open the floor for questions, so we'll have an open discussion. And over the course of our panel discussion initially, please feel free to use the Q&A function to raise any questions or to direct any questions to panelists, either specifically to one of them or to the group, and I'll direct it in the discussion. If you feel like and want to comment on some of the things going on, you want to have a discussion, you can also use the chat function for that. So the Q&A function is for questions that you'd like me to ask the panelists. So now that the housekeeping is over, I'd like to move on to the 3 panelists. We are joined today by Violet Naanyu, Eric Racine, and Anna Chiumento. Violet Naanyu is an associate professor in the School of Arts and Social Sciences at Moi University in Kenya. She holds a master's degree in medical anthropology and both a master's and a PhD in sociology. She's a member of the National Bioethics Committee in Kenya and is also currently pursuing an MSc degree in global health ethics. Her research focuses on individual and sociocultural factors around illness, health, and healthcare. And Violet has published a wonderful book on stigma and mental illness. She is passionate about global health ethics and is especially interested in evaluations designed to improve care and well-being in resource-limited settings in Africa. Violet will be followed by Eric. Eric Racine is the director of the Pragmatic Health Research Ethics Unit at the Montreal Clinical Research Institute in Canada. He is leading large international research in bioethics with recognized contributions to the development of neuroethics and pragmatic ethics. He is the author of Pragmatic Neuroethics, Improving Treatment and Understanding of the Mind-Brain, published by MIT Press. Inspired by philosophical pragmatism, his research aims to bring to the forefront the lived experience of ethically problematic situations by patients and stakeholders, and then to resolve them collaboratively through deliberative and evidence-informed processes. Eric will be followed by Chiumento, who is an applied social science postdoctoral fellow in global mental health at the Department of Primary Care and Mental Health at Liverpool University in the UK. She has a specialization in empirical ethics approaches, with her PhD and postdoctoral research focusing on the lived experiences of what it means to conduct research ethically in low and middle income countries. She also has a strong interest in the normative dimensions of healthcare delivery, such as the implications of task shifting approaches. Her research focuses on the applied research practice interface, developing and testing mental health interventions or instruments, and empirically examining the practice of healthcare and research in low, middle, and high income health systems. So without further ado, I'd like to invite Violet to share with us some of her opening thoughts. Violet, over to you.
Thank you very much. So I have 7 minutes. I would like to say that I'm honored to be on this panel to talk about something that's extremely important in our globe today. I serve as associate professor in the School of Arts in Moy University, and I serve on the National Bioethics Committee in my country and on the Africa Ethics Working Group. And I will talk a little bit about that. I'm mainly going to focus to share with you my experiences on what I see as the role of bioethicists in ensuring that the research that we are carrying out is safe, it's ethical, we are respecting participants, and if there are any compensations, we are remembering that even as we design the studies and not necessarily at the end of our studies. So what's vulnerability all about, and why do we fuss about it? Using a broad definition, we're talking about members of our communities who are disadvantaged one way or the other. And when you look at people with mental conditions, you will find that they're relying on quite a number of people around them. And when you use an ecological model, the immediate people would be their family or the immediate significant other. Then there's a broader society, and it's a challenge, especially I come from Kenya, where our mental health system is still struggling to put things together to ensure that these members of our families, of our society, actually get the best care available. So they're disadvantaged already. They're unable to cope quite often or resist harm. And when we now go ahead and engage them in research, we as researchers of integrity need to pay attention to these particular vulnerabilities that come with being in that condition, and see how best to ensure we protect them and the people around them. So here I see the importance of the person we call the LAR, the legal authority representative. We are talking about people who may be quite unwell at some point when we are recruiting them, or their capacity to comprehend a 16-page consent form is limited. So we want to be sure that when they're unable to do this, there's a witness who is legally able to consent and understand fully the projects that we are enrolling these participants in. The reason being, we're aware of their diminished capacity and therefore sometimes quite often lack of autonomy in making solid decisions. So I have 4 main points that I raise around the ethics of engaging them in research. And these are points I'm hoping we as investigators across the globe, and also especially in the low and middle income countries, would pay attention to when we're enrolling our participants. The first one is the issue of competence. We need to be sure that a participant who is enrolling in a study fully comprehends, has the competence to process that which we're talking to them about. They fully understand the procedures we're telling them they will be involved in, and they have understanding of what being involved means. What are the implications of this? So we need to be careful to be sure that when they are very sick, when they are unable to give valid consent, we pay attention to that. And this ties closely actually the second one. This is voluntariness. How sure am I they're able to say no? We always talk about saying yes. Have they said yes to the study? How confident and how sure are we that this participant with a mental condition is able to say no when they are actually at our mercy quite often as caregivers who and healthcare providers who are often involved in research, recruiting them? Are they voluntarily actually willing to be part of the study? Are they willing to sit through a 1-hour interview or just a 10-minute one? How sure are we they're saying yes? Are we respecting their person? So voluntariness, we need really as researchers of integrity to pay attention to that. And the third thing is comprehension. There is the competence bit, but then you have to ask yourself, even when people don't have a mental condition, have they fully understood what their role in the research will be? Have they fully understood I'm taking their sample and it's going to be stored for this length of time and it will be used in a future research in the following way? All these details, do they fully comprehend? Are we using the right language? If it's not, if they are illiterate rural populations, for example, and having a mental condition, who else? This LAR that we're engaging, the legal representative, are they also fully comprehending what we're talking about? Must we enroll them? Must we enroll them in this study if they're not fully comprehending? And how are we able to check for comprehension? As you're aware, there are quite a number of tools out there that we can use, like the UBAC, to make sure that we confirm that participants are fully understood what we're saying. And then the other key thing is about benefits and compensation. When we get a good product out of this research, issues of access. These are people already having multiple vulnerabilities. Have we considered access to that product thereafter or even during an emergency? Have we told the sponsor that this may be necessary, we as researchers, and ask them to budget this in as an important line item? So we need to reflect on that. And sometimes when we're saying, oh, because of this research, these are the following outcomes we're expecting, are we maybe making it so glossy that they say, oh, wow, this looks like it's going to bring us some goodies. I need to enroll. So we need to pay attention to issues like inducement when we're talking about what will come with the project at the end of the project. So here I share with you what we call the Africa Ethics Working Group. It's been a pragmatic group that just been guiding principal investigators in 4 countries, Ethiopia, Kenya, Uganda, and South Africa. We mainly were involved between 2017 and 2019, towards the end of 2019, when the projects were starting and rolling out, and the implementation issues of social and individual level ethics came up. So we are quite a rich group with all kinds of background, as I'm showing there, the expertise in psychiatry, philosophy, social sciences, and we would meet routinely and reflect on issues coming from our sites and discuss them on a common group. And we gave a lot of advice, even as the protocols were going through the IRB, and also thereafter as they started training the research assistants and rolling out the projects who were available to the PIs. Whenever they came across an obstacle or an issue that had to do with ethics, they turned to us, and we as the site ethicists supported them, and when we were unsure, we also bounced the questions to the larger group of the ethicists across the 4 nations. We found this very, very helpful. And this slide shows the members across the nations, as you can see, from Ethiopia, from Cambridge, Kilifi, and then I and my colleague Eunice from Moi University Eldoret, and we have the team from Ethiopia and from South Africa. And Professor Elena Singh has been our lead in the ethics, Africa Ethics Working Group. She's been amazing. So here are some of the issues that came up from the 4 projects, from the 4 sites, and I tried to arrange them quickly this morning to just show the kind of issues that came up. You can see consent came like 10 times as an issue for the Africa Ethics Group to support the PIs, issues of photos, consent for photography, return of results, issues about benefits and compensation, translation, comprehension, issues about recruitment, privacy of data. Then in one particular country, the IRB capacity to review the protocol, because the protocols were on genetic studies. This raised a concern, and we discussed it, issues of study training and engagement issues in the community. So you can see a broad list of things come up when the PIs are rolling this out. So without a team of bioethicists or a place to tap for support, sometimes the PIs really struggle and they have to rely on the ethics committees. to give them guidance, and that can slow things up. So this is the first time in my own experience, a PI called on me, not to be a co-investigator, but to be on the team to give advice around ethics. And I thought this was really cool. So this is our group. We started, like I said, in 2017. In 2020, we mainly stopped all the the mainstream activities for the two projects, but we decided to continue working together. And so we've been looking for grants and other issues that we can support around Africa on these issues of ethics. And yeah, they're a happy group. And so that's the end of my presentation. And I hope you have enjoyed it. Over to you, Jantina.
Excellent. Thank you, Violet, for that really interesting reminder of the range of ethical challenges really that we need to take seriously and consider. Eric, can I invite you please to share your opening statements?
Sure. Good morning. Well, I guess good afternoon, good day, everyone. Good morning here in Montreal. I'm really delighted to join this panel, and it's so amazing to see the representation that we have in this forum. It's really, I think, the globalist audience I've ever addressed in my life. And what I'd like to do this morning is just to share a little bit with you where I'm coming from for my opening remarks, and then describe to you maybe 2 or 3 challenges we've encountered in our work in researching ethical aspects of mental health and neurodevelopmental disability, and then maybe a short conclusion. So in terms of my angle and where I'm coming from, I think especially that we have such a global audience this morning, I think it's a really nice opportunity to ask, in the context of mental health research, but also beyond, what is really the purpose and meaningfulness of research ethics? We have oversight mechanisms. We have a lot of research ethics guidelines, but in the end, is research ethics doing its job? And is it doing its jobs and fulfilling its mandate in the context of mental health? I would really love to hear from others in this group how they feel they are supported in addressing some of the important tasks that research ethics needs to do, namely, for example, making sure that our research participants are informed and empowered to make decisions. And then second, that they are really protected from undue harms of all kinds. So that being kept in mind, I know it's a very broad question, and I hope we can somehow address it this morning. But my job this morning is much more to speak a little bit as an academic bioethicist who has done some research, a couple of projects on mental health situations in research and also in neurodevelopmental disability, and share a couple of the challenges we've encountered. And I have 2 or 3 of them to share with you. So one of them, first one, is really the challenge of doing research on conditions which are basically almost always on the spectrum. And because those conditions are on the spectrum, there's really a wide range of situations and of abilities and capacities of people we do research with and research on, so to speak. That means, for example, that immediately, if you're doing research on autism, for example, you get engaged by questions about how you name your research participants and how you engage them, since they have it represents such a wide range of people in the end. And so that's one immediate challenge we've encountered in doing research, for example, in neurodevelopmental disability. Another related issue we face when doing research on cerebral palsy, which is a chronic and mostly physical neurodevelopmental disability, but it has a neurological basis. But that neurological basis induces a lot of conflation about the giving the impression that these people do not have the ability to speak on their own or not able to participate to consent, for example. So we were doing research, we're intending to do research on children or teenagers with cerebral palsy, but actually we faced a lot of difficulties in dealing with our research ethics board or research ethics committee because they felt that this was a highly vulnerable population, and all we wanted to do is actually voice the concerns, the moral problems that these youth were facing, and we encountered a lot of red tape, so to speak, in doing that, because immediately the research ethics board felt that this was a highly vulnerable patient population, and though it kind of reinforced the problem we were actually trying to fight against, which was making sure that a patient population that had basically never been asked to share their views on moral problems they were living with had the opportunity to do so. So that was, so dealing with conditions which are on the spectrum, I think is complex and generates a lot of different questions and issues on a practical basis. The second challenge is meaningful engagement. I think we all want to do research that is meaningful to people who have mental health conditions or neurodevelopmental disabilities. We want to have an impact. We want to help voice their concerns. We want to make a positive contribution. And we know that to do so, we want to basically favor their participation. We want to facilitate their participation, I should say, and their engagement. So one immediate challenge here is often there are gatekeepers. There are healthcare providers or their parents or carers that are taking care of the people we want to do research with. And that creates challenges in terms of being able to engage more directly those participants. A second issue is, and it relates a little bit to the first challenge I was speaking about, is so the first issue we've encountered a couple of times in our work. A second related issue is when we were trying to understand stigma in the context of fetal alcohol spectrum disorder, and highly stigmatized condition in Canada, and it's highly stigmatizing for women who give birth to children who have this condition because it's related to alcohol consumption during pregnancy. So we were trying to understand stigma, and we were doing focus group research with people affected by FASD, and we were using media prompts, so Canadian media content that was sometimes positive, but sometimes negative. And in doing our piloting, we got some feedback from some stakeholders saying, hey, wait a minute, the media representation that you're using to engage people about stigma is also very controversial, very damaging, very prejudicial. So we realized that our research, which was meant to engage people, was maybe not suited for all people affected by FASD. So we had to react and readjust our study. So this was a challenge in trying to do meaningful and engaged research. Yet a third challenge, if I can mention a word about it, is trying to do research that relates to research participants as persons, as full persons. And this is sometimes something that flies in our face, because I think in this line of work, we're doing research with people who are often very much marginalized by society, but also by our public services, education, healthcare system, and so on. So people who are at the margins, and when there's an opportunity to participate, they are sometimes so appreciative that it creates difficult situation for researchers, because we're not prepared to hear very touching testimonials about their life experiences, and they catch us a bit unguarded, if I can say us in our research our research team. And we've encountered this situation, for example, when we were piloting material, when we were doing research on mental health, vulnerability in the context of mental health research. We were piloting our study materials, and I was actually moderating a focus group discussion, and there was such an appreciation, a positive appreciation, that we were simply asking people what their views were as persons. That that simply creating that space opened up a lot of life sharing, so to speak, life experience sharing, that go beyond, I think, what we expected out of this small piece of research. And another time we were doing participatory research in autism, and through a concept that I'll say a word about in my concluding remark in a minute. And it was, I think, appreciated. And in the end, one of the mothers who was participating was so touched by the experience that she cried at the end of the work of the task force. And again, I think this speaks to the value of engaging people as persons, because they don't often have a space to voice their concerns and be engaged as full persons in the research process. So I want to conclude by simply restating that I hope we'll have an interesting discussion about the very, I'm assuming, very diverse experiences we have with research ethics. And I simply want to conclude that in our work, we've encountered these kind of everyday research ethics problems, and this has led us to develop a concept that we call person-oriented research ethics. And it's structured around a number of guiding principles that all, and this is published, if you're interested, I can share details about this, but the idea of this line of work is to bring attention to the everyday research ethics concerns that we encounter as researchers or others encounter, and are not necessarily well addressed by the kind of regulatory research ethics that we typically have as a tool in our hands to work out these kinds of situations. So I'm looking forward to the discussion, and this will be the end of my opening statement. Thank you again.
Excellent. Thank you, Eric. A lot of food for thought and some interesting convergences or overlaps between some of the things Violet was saying and your own observations. And I think you problematize some of those concepts that we fling around all too easily, and actually say, well, what does this mean when we involve people who have mental health conditions in the research that we do? Anna, may I invite you for your opening statement, please?
Thanks very much, Jantina. Thank you to Eric and Violet as well for what they've gone before. Hopefully, what I'm going to talk about will kind of build on the points that they've raised so far. I've chosen today to focus my opening remarks on the important issue of positionality, and really trying to think about this idea of internalizing ethics and us as the researcher. So positionality it's a very broad term. It captures how we as researchers view and interpret the social worlds in which we are embedded. Our perspectives are shaped by who, where, when, and how we are socially located, and by our individual experiences, beliefs, and values, all of which shift over time. So exploring positionality is important for the ethical grounding of mental health research, because the position from which we see, experience, and know the world impacts every stage of the research we conduct. And in particular, it shapes how we engage with people with mental health conditions. So, for example, there are some very obvious elements of my positionality. I am female, I'm white, I am British, I have a Western upbringing, and they make up kind of who I am and where I am located, which in turn shape my exposure to and understanding of mental health and well-being. And this has really come to the fore recently for me in a project that I'm currently involved in with an Indigenous community in South America, whose orientation to the world is vastly different from the Western, individualized and material-oriented position that I've grown up with and am embedded in. And as part of this research and learning more about Indigenous worldviews, I've come across the Mi'kmaq community in Canada, who have a really interesting perspective that's been applied to research of two-eyed seeing. So the idea that researchers embrace with one eye, seeing with the strength of a Western way of knowing, and with the other, an Indigenous way of knowing. And using both eyes together brings these together. And I find this a really useful way of thinking about global mental health research, where we're engaging with and working within communities who are likely to have very different views about and understandings of the world around them. So I'm sure for many of you conducting this sort of work, that you will have encountered communities with different understandings of the causes and the treatment of mental health problems. And similarly, as Eric was highlighting, sometimes, in fact, this is very clearly drawn out in sort of ethics review processes and these different ideas and different perspectives on how we can ethically engage with communities. So exploring positionality also involves recognizing what motivates us to conduct mental health research. So for me, what underpins most of the work I do is an aim to promote the values of solidarity and care. The other important component, I think, that's important to recognize is the way in which we're constantly being shaped by the relationships that we engage in, both with research participants and with other researchers. And as has been previously highlighted, this includes participants often sharing intimate details about their daily struggles that arise quite naturally often in mental health research, and that can raise underpinning issues of inequalities and social justice. So for me, for example, when I've been reading transcripts from a recent study conducted with Congolese refugees living in camps and settlements, I was really very aware of the emotional labor of engaging with those sorts of intersectionalities of challenging stories and living situations. And they were emphasized further as the political narrative in the UK becomes increasingly anti-immigration. And similar tensions arise in mental health research across the globe. So we are too often faced with participants who are experiencing human rights abuses, such as being chained up, or we're interacting with those who've been socially excluded and are living in extreme poverty due to their family or their own mental ill health. And these situations can be very painful to witness. They can create feelings of powerlessness and frustration, as well as guilt at not being able to do more to help. They inevitably reinforce the privileged position of the researcher as someone who can step away from the situation back to the relative safety and comfort of our own homes and families. So, for example, in my PhD, I found the fact that I was removed from the situation of my participants due to concerns for my safety, which led to part of my research being conducted online. So I was in a capital city in relative safety, whilst my participants were in a conflict-affected region. And something that was very visible to me as well as a result of power cuts during our conversations and the fact that they were available to talk to me due to curfews. So this situation raises real discomforts around privilege and safety and worries about the lives of those I was talking to. And COVID is another big example of that. You know, I've been able to ride this out in the UK, whereas the participants involved in research that I've been conducting are in locations where they don't have that same access to safety and security. Now, there aren't really any magic solutions to these feelings or situations, at least not until human rights injustices and conflicts are fully addressed worldwide. Some things that I actually find really helpful is around practicing actively self-care strategies. I really love going out for walks with my dog or meeting up with friends. And I'm also active in a refugee charity here in Liverpool. So trying to practice those values of solidarity and care towards those fleeing conflict and violence in my everyday life. And these small things help to manage the emotional impact of the research that I conduct to ensure I'm able to continue and don't burn out. And really, one thing I'd like you all to take away is to really think about and find similar strategies to protect your own well-being, but also to recognize when the research that you do is having an impact, and seek support. Other aspects to these examples of positionality raise are issues of representation and the ethical responsibilities we have as researchers entrusted to advocate for those in need of mental health support by retelling their stories. And here I strongly believe that language matters, ensuring that the language that we apply is appropriate to the situation and the population we are engaging with. So my research primarily falls on the psychosocial end of the spectrum, with communities exposed to humanitarian emergencies and who are generally responding to the stress and upheavals that result from this. Things like migration, loss of home and homeland, witnessing and experiencing violence, among others. So in this context, I'm personally much more comfortable with language of distress rather than perhaps of disorder or illness that's more medicalized, as I feel the kind of more medicalized terms risk reinforcing stigmatizing attitudes rather than treating people with dignity and strength by normalizing reactions to stressful experiences. And this issue of representation also exists in preconceptions about the communities that we work with due to migration status or mental health status, or, you know, in my case, I've made unfair assumptions based on things like English language skills. These preconceptions can be hard to overcome. We all need to commit to working to be aware of how we engage participants and communities to ensure this is respectful and ethical. And this starts with recognizing who we are, where we're socially located, and what assumptions we're bringing about who we're engaging with and where their agencies and strengths lie. So these examples, I hope, really highlight how thinking about positionality can raise a range of ethical considerations that underpin many of the everyday aspects of conducting global mental health research. Ways to respond to these need to be contextually appropriate, attuned to the experience and skills of the researcher, the sensitivity of the research topic in the setting, and the worldviews of the communities involved. For example, some core orientations I've applied include actively seeking to learn about a community, both through reading and through direct engagement, as well as being attuned as I can be to language, nuance, and meaning, and also behaviors of participants. For example, there's normally a reason why people are deciding not to engage in research. And to aid this, I really rely on collaborations with skilled local researchers with whom I have relationships where I try to really seek an openness. This is often established through little things, getting to know them and their lives, their families, doing things like having lunch with them or going for dinner with them. Those small everyday interactions where you build up relationships that hopefully lead to the trust that you need for your research team and the local community to be communicating back with you and breaking down those perceived power hierarchies between their local and my Western lens. Other approaches, such as genuine co-production and involvement of those with mental health conditions as researchers or as project advisors, are really important strategies to challenge the positionalities and the assumptions of the researcher. So paying attention to and critically considering how we respond to our individual and collective positionalities can help to ensure the work we do is ethically grounded. Practicing and promoting values of relationality, solidarity, and care in and through the research we conduct. It also can make us more honest and self-aware so that we become better researchers as a result. Thanks very much for listening, and I look forward to seeing where the discussion goes.
Excellent. Well, thanks, Anna. I'm going to take it into interesting directions, I think. So if I can invite the panelists to all put their videos on. Adrienne, if you are listening, I'm sure you are, maybe a quick update in the chat. I presume we have everyone's emails of everyone who registered. And so any relevant resources we'll send through. So there's no need to offload your email addresses in the chat. Great, thank you, Violet, Eric, and Anna for those opening statements and those initial ideas. I know we had some questions prepared, but I'm actually going to shift focus a little bit from what we had thought we would speak about and ask you about something that Eric really mentioned, and that came to kind of, into my mind, as I was listening to Violet, and I think your statements on positionality brought that home for me, and that is the extent to which systemic bias or systemic internalized bias, any kind of bias or stigma attached to mental health conditions affects not just our own relation to research participants, but also the ethics or the judgments that we make about people's ability. So Eric spoke about an experience where ethics committees were becoming very paternalistic or very protective over involving people with mental health conditions in the research. Violet is aware of the work of one of my colleagues, Megan Campbell, who looked at, these assumptions about agency when people suffer from mental health conditions, and kind of protective attitudes saying, well, actually, these people cannot decide for themselves. And in a study that she did, found that actually there's no grounds for this, right? In that study, it involved people with diagnosis of schizophrenia who were perfectly well able to make decisions about really complex aspects of genomics research, even though the ethics committee had been very worried about that. And so I wanted to ask you whether you could just comment about, Eric, I know you've started doing that already, but about how we guard against our own stigmatizing beliefs about the abilities of people with mental health conditions, and how that affects how we involve them in research. So what we can ask, and what we exclude people from. Eric or Anna or Violet, if you want to. So how has this manifested in your research?
Yeah, so I shared one experience, and this has come up a couple of times, in our research. Sometimes hearing like very condescending comments towards our research participants that really surprised us. Very shocking in a sense, but very revelatory of, social attitudes towards people with mental health conditions. Things are changing, and stigma is diminishing, I think. It's becoming increasingly, accepted to share difficult life experiences. We're seeing, at least here locally, a lot of progress in that direction, and this is really reassuring. But even I started as a principal investigator 15 years ago, and things have changed in 15 years. So I think there's hope for change. Society is changing. Research ethics is also becoming less paternalistic. There is still some remnant of that in our research ethics oversight. I think one way to guard against this, I think, is to adopt for ourselves and try to promote for others a learning stance towards others and towards life. We can learn, and we don't know everything about other people. So when we engage people who have different conditions, different life experiences, let's be open-minded about what they can actually do, what they're able to do. Let's not apply too many assumptions to how things will turn out or things can be. And let's work with other people. Let's work with others to make things happen. So my approach, and that I'm increasingly trying to promote and apply in my own research, we're doing an increasing amount of participatory research, is to have an open stance about exactly what people can and cannot do. And very often, I think we'll be pleasantly surprised on how much we can engage people, how far we can go, and we will learn and therefore correct our biases and our assumptions. And we'll have others like our research ethics committees. If we tell them about this and we tell others how far we can go. And in our work on person-oriented research ethics, we've found so many examples, for example, in dementia research or autism research in the two contexts where we've applied and explored this framework. Simply reviewing what others have done, there is a considerable wealth of practices to engage meaningfully research participants, all kinds of creative ways to debunk different biases and assumptions. So I know we are often coming from kind of a difficult and kind of negative, kind of overcast, but I think we can very much progressively move away from that. I think we are actually, and there's so much in the literature that can guide us.
Wonderful, thanks, Eric. Anna or Violet, any?
I was going to pick up on a couple of things. The first thing that came to mind actually is around the research ethics review processes, and this is something that I looked at in quite a bit of detail. And the challenge is with a very standardized approach to ethics and a kind of lack of contextualization, a lack of thinking these things through. And I wonder, the first thing that sprung to my mind is whether there are opportunities for us as researchers to be using the space of those ethics forms and those processes to advocate for, and instead of thinking about risks and vulnerabilities, to be thinking about strengths and agency, and, you know, where are the opportunities for us to present that voice and to present that I guess, you know, the vision for where we want research processes to go. The other thing that I think in doing that is to be, as Eric was highlighting that, you know, to be co-producing, to be co-developing this, to not assume that perhaps we are already fully equipped and we already have all the tools for doing this ethically and appropriately, but really to ensure that we take the time to engage with people with lived experience who can help guide us, and really that should be our ethical benchmark, much more so than the ethical review committee at times, or the two should be working in tandem. Of course, I don't want to sound completely naive with this, because we're researchers. We work in time-bound constraints. We need the approval to kind of it's often said to me to move to the important work of actually conducting the research. So there are a lot of tensions here in the everyday work that we conduct that need to be negotiated. And you know, often the simpler route is to simply write what the research ethics committee want to hear, so that you can move to the work of doing research. But equally, if we are going to really help the culture of research ethics to evolve to one that is supportive of a whole range of research types, and you know, we're talking about it in the context of mental health research. I've had similar discussions in the context of implementation science research and the types of approaches that involves, and you know, essentially needing to work with and educate committees to enable them to facilitate our research. They're not necessarily approving, that the process should be one that's supportive, that's facilitatory, and that enhances the ethical grounding and the kind of foresight and planning that we are engaging with for that process. So those are a couple of thoughts from me. I'll let Violet chime in.
Great, Violet.
Thank you, Jantina. Thank you, Anna and Eric. Nothing much to add. I think for me, the key thing is, I would say, self-reflectivity. As we say in anthropology, we need to realize that we as researchers affect the field as much as it affects us. So if we already are dealing with we are stigmatizing and we don't even know we are prejudiced and all that, we need to first reflect inward before we do this. But if a research question, there's a gap in knowledge, we realize it's either a national concern or a state concern, or in your health facility, the issue has come up several times, we owe it as academicians, as researchers, to take up the matter and write protocols around it and research and inform care and be conscious of our biases. That's all I would add. Thank you. Over.
Wonderful. So that brings me to another question. So just for the audience, keep on typing your comments. I'm keeping an eye. I'll open it up for those questions in about 10-15 minutes. So keep those questions coming. The second question that came to me when I was listening to the contributions is one about, it's an intersection between something around ancillary care. Violet mentioned, doing research in really resource restrained settings. And I don't know what the situation is in other parts of the world, but certainly in South Africa, psychiatry, mental health is just about at the bottom of the funding agenda. There's no sustainable funding often. There's few psychologists and psychiatrists in the healthcare system, and it's difficult to access care and treatment for mental health conditions. And so the situations are really harrowing, right? The need is dire. And as you involve research, as you involve participants who suffer from conditions that are not being met by the healthcare system, the stories you hear, I mean, you all three refer to different kinds of stories, right? That you hear are also really dire. And so the question to you is really to reflect a little bit both on two aspects. One is there then is often an expectation for ancillary care, right? Or a request. And sometimes these requests are really easily met, but they might not have been covered in your research protocol. You might not have funding, whatever. Sometimes they're not that easily met, right? You can't change people's lives. If you can just reflect a bit on both what you think or how you have dealt with kind of ancillary care types of expectations and obligations in your research, and associated with that, how do you deal with your own well-being, your ethical resilience? Anna, you alluded to that in your opening statement a little bit, and Violet and Eric, I'm curious to hear from you. How do you deal with processing and doing justice to people's stories when actually they don't leave your mind? And so I'll direct the question to you, just to say that I saw that Sassy Molyneux earlier in the chat put in a link. Maybe Sassy, if you're still on, you could put it in again, of a website that collects resources of how people kind of deal with the everyday ethics. So that might be a really useful resource. But over to maybe in reverse order this time. So Violet, if I can direct this question to you first, and then maybe Anna and Eric.
Okay, that's a big one. As you have said, Jantina, we're talking about a context. I'm reflecting on places where I work in Western Kenya. You go to a facility, there's barely a mental health team to help with mental health conditions. There's one psychiatric nurse serving, the whole region, and one psychiatrist who comes in once in a while from a neighboring big town. So the infrastructure, when it comes even to the meeting rooms, the tools needed, the equipment to see patients, even just the forms to do analysis and record what it is they're doing, in short supply, or they have just never been there. So when you talk about justice and supporting, so you go in as a researcher with a research question and a budget that the sponsor says, this is a line item for this. And where the rubber meets the road is this patient is in front of you, they haven't eaten for God knows how long, or they need immediate support. And so this is where I talk about the ontological value of people who cross our paths. Let's be human first. And as a researcher of integrity, operate from the heart, not just from the mind. And so what we do, and allow me to mention the Empath Research Consortium in Western Kenya, is it called the logo? The title that goes with our consortium is We Lead by Care. The thing that the founder said, when we meet patients, we have research questions, but we first respond to the immediate need on the spot. So sometimes we've gone to places and there's no running water. And they say, yes, we've heard you, we are consenting to participate in the study, but would you bring us some water? And so sometimes we've had to go back to the teams and to the sponsors and say, they are receptive of this study, but the following things, and they cost only this much, are needed just to be human and to respond to the immediate needs. The issue of giving feedback, like samples after collecting, biological material for research, and you find that, there are conditions that even the participant didn't know about, and just going back and saying we can do something about this, or building capacity of the nursing staff and the medical officers or the labs, equipping with, fridges and other materials needed for analysis. Just going back and leaving that even at the end of the research period to ensure that you're responding to where the rubber meets the road with a limited budget, because as Anna said, really, we go in as researchers and you can only operate within a certain box. But I'm saying, when you speak from the heart, even sponsors listen, because you go and say, I went in, it's been 1 month, and this is when you're doing your report, this is what even your advisory board needs to know. And so then we see what else we can do beyond the research agenda that took us there. And people have been very warm and very supportive, and they understand that we have limitations as researchers. But from experience, I've noticed that sinking that borehole that ends up changing the life of a whole village, sometimes it's not as expensive as we think. Over.
Wonderful. That's a wonderful note of optimism. Anna and Eric?
Yeah, I mean, really, to build on all of the things that Violet was saying there, this notion of engaging kind of as a person, I guess, picking up on Eric, what the things that you've been talking about, really thinking about people in the context of their lives and being as person-centered as possible. But it is a challenge, certainly in studies that we've been doing in South Asia, for example, with school children, and you're sort of going in and you're trying to think about how we can work with teachers to support the mental health needs of these children, or engaging with their parents. And the sort of attitude and the response that you get back is essentially, well, my children don't have shoes, I can't afford, even these kind of very basic elements that a lot of us take for granted. And what's the response of the research team when you're conducting research into mental health problems, to be thinking about those social and systemic issues? I guess a few things that we certainly have tried to implement in the majority of projects that I've been involved in have been, firstly, to ensure that the research is integrated into those systems. So trying to be working with the existing policymakers, the existing structures where there is the possibility for change, but on a more sustained level rather than kind of individual participants. The other thing in terms of more specific ancillary care is thinking about, and Violet spoke to this, thinking about the opportunities for enhancing training and capacity building, so that there is, you are leaving a bit of a legacy there of people who can hopefully respond to this better in the future. It doesn't address the kind of end of the line issues of lack of psychiatrists, for example, in a country, or those mental health specialists. So it's limited in what it can achieve. But by doing things like, for example, in a lot of settings, we've implemented what we would call enhanced usual care. So it's recognizing that the usual care that people get is highly stigmatized and is problematic on an ethical level, and seeking to enhance that to a level where participants are being treated at minimum humanely and are being offered something rather than nothing. There's also, a responsibility, I think, here around ongoing advocacy, and within mental health and global mental health in general, there often seems to be a tendency towards trying to fill gaps rather than necessarily standing up and saying, the reasons why we need to be investing in this. And there are very clear, and there's years and years of research. And it's how we transition that to be an issue that is prioritized, and that is given the funding that it both needs and deserves. And I think that advocacy component and seeing the more systemic change is one way in which you can support your own ethical resilience. Because actually, at the end of the day, we all do this work because we believe in the potential outcomes, because we want to invest in and support people in the long term. So that for me is a fairly significant component of that kind of ethical resilience. At the same time, I think if I wasn't being affected by, if I wasn't sometimes distressed by what it was I was hearing and coming into contact with, that for me would be very worrying, because these the studies that we conduct, the lives of people that we are engaging with, they are fundamentally challenging, and there are a myriad of issues that potentially need to be filled there. And just as a very final point, I think there is a real responsibility to have these discussions on a team level. Patricia Kingori in her work has obviously explored the ways in which research assistants sometimes end up filling gaps, you know, the kind of buying of medicine for somebody, or the provision of, you know, lunch or other things, because they feel morally obligated to do that. And actually, I think, you know, particularly when it comes to the more senior members of research teams, that needs to be a discussion, and that needs to be something that's recognized and opened up, and kind of the moral, they are the people who are having that interpersonal encounter, and that is where the moral discomfort arises, when you are in somebody's home, or, you know, they are inviting you to share what little they have in a meal. And actually exploring and addressing that on a team basis, and coming to a solution that feels appropriate in the context and in light of all of the other constraints that we're working under, feels really important. So I'll stop there. And Eric.
Wonderful, thanks, Eric.
Not sure I have too much to add following those very thoughtful remarks. I think we are doing better than we used to in terms of foreseeing or anticipating these kinds of situations. There was a time 15, 20 years ago when we were not even talking about incidental findings in research and providing resources, having people there with us when we're not equipped, when we don't have the clinical skills to have, for example, psychologists and social workers accompanying us in our research. These are now practices that we are implementing, that we're actually following. We're actually being asked to do these things. So there's been progress in recognizing that we need to do more. But at the same time, there are important limitations, as Anna was pointing out. I mean, and I think part of my role as a mentor, a research supervisor, has been to remind, you know, younger researchers that there are limitations to our work. We are researchers. We cannot repair and fix the world with our research, with one study. And this is very difficult, very challenging. And when we face difficult situations, it is distressing, to use Anna's term. I think and it's an eye opener. And I think we have to use these opportunities to learn. To do that, we need to be open-minded to being challenged. And I think, as Anna was pointing out, this is part of the work we do. So we have to kind of realize that it is part of what we're going to be discovering are these unexpected and difficult situations. And we will not have any kind of quick fix or magic solution to them. They may actually be contradicting or challenging deeply our research orientations, because we can't really do anything about it with our own research. So what do we do with this? These practices we're pointing out, we need to talk. We need to address this as a research community, as a team. Even supervisors need to be open to being challenged, to listen to their younger colleagues who will be challenging the orientations we take, the practices, to learn about maybe the wrongs that we're doing with our research practices and try to do better. And then once we realize this, it is distressing, but I think what we need to do is not to forget. And when there are difficult situations like this, it may not be addressable with our current research protocol or research study. We'll try to do the best we can now, but for the future, maybe this is something that will change our research program, lead us to new research questions, lead to a new student project about the unaddressed needs that we encountered in a study. And this is sometimes what has happened in my research team, that we've encountered a difficult situation, could not really do too much with it at the current time, but maybe in our next research, we'll do things differently. We'll be more engaging, we'll be more participatory in a way that will offset some of the problems we've encountered. And if we publish about these things, we talk about these things as we're doing today, we'll be progressing and doing things, I think, and probably in a kind of improved or more ethical way in the future.
Thoughtful comments, and again, I like the call to action and the reminder that simply because something is difficult doesn't mean it's not worth doing. Want to turn to some of the questions and would ask the panelists to be a little bit concise in your responses so that we can get to a few. There is what I find quite an interesting, so I'm going to use my discretion here and pick and choose some of the questions. So there's an interesting question by Action Amos, and Action, thank you for raising it. He writes that in his work and research on NGOs, ethical practice and mental health research, he's noted that there's really limited sustainability in the mental health research agenda. And the rest of his question kind of, basically he's asking you to comment on how should one go about developing a sustainable mental health research agenda. Violet, I see you've started typing in LMICs. Violet, I see you typed some responses. Do you want to bite off a response to that question? So it's about research agenda setting, really, and making sure that the mental health research that we do is sustainable.
Thank you, Jantina. Thank you, Amos. Sustainability is always the elephant in the room. So I don't have answers for that, but setting the research agenda, allow me to reflect on my own country. I'm from Kenya. The research agenda, right now, there are priorities at the national level on what areas of research the government would like to see researchers pay attention to, besides everything else we want to do. And I've been encouraging, whenever I've had talks on research at the state level and in the universities, I've been encouraging specific counties. In Kenya, we are segmented into counties. Each county needs to reflect on their health data and the conditions that the populace lives in, and actually identify things that are also very specific to those counties. So setting up a research agenda should be informed by observations, the lived realities of our communities. And the reason I asked about stakeholders is that I wasn't sure what Amos said in mind, but usually setting up those priorities requires a panel, a mix of all types of stakeholders, all the way from the grassroots, like the example I've given, because it's a lived experiences being turned into priorities and being panel bit in order in a way that they are deliverable to the institutions for people to write grants and look for the money. So what I would say, for it to be meaningful, and therefore, in the end, whatever work is done sustainable, it needs to have that human design-centered approach where we don't leave out. If it's about disability issues, we need to have the people, a representation of people from those types of conditions. But in Kenya, I have to say, it's not that very engaging, like involving the patient groups and things like that. Not yet, we are not there yet, but I'm aware that researchers currently, most of the research we are doing in the Empath Consortium is very people driven. We are engaging both the supply side and the demand side when we are implementing, when we are reviewing what we are doing and when we're giving feedback. But even more so now, we're beginning to engage them when we are writing protocols. We reach out to the government officers and medical officers working in clinics on the conditions that we want to work on, so that we make sure we are actually writing protocols that are meaningful to those specific contexts. But sustainability of a research agenda, I've never thought about it that way. I think about more of sustainability of the interventions that probably our research leaves behind. And from the experience we've had recently, when you engage the Ministry of Health early, and then the counties we go to, we engage both the supply side and the demand side, we have found ownership going up even when we exit, they absorb the nursing staff, the clinical officers, the community health volunteers that we engage in our research. You find the county governments begin to absorb them as employees in the healthcare system. So that's how I see it when I think of sustainability, but I already said I'm narrow on that one, so over.
Thank you. Any thoughts, Anna, or any further contribution, Anna or Eric?
I can make two very brief points. So the first is around, you know, obviously priority setting exercises which do happen within the academic world. They sort of happen on an ad hoc basis, I guess, to try and think about what are the key research questions that need to be addressed globally. I'm not sure that those exercises are always as inclusive as they could be, particularly of voices from LMICs. Often the emphasis is on academic researchers contributing, and actually, as we're talking about, there really should be much more of a diversity of voices, so from experts by experience, as well as policymakers and others. And I think the other point around the challenge to the sustainability of a mental health agenda is the issue of funding. You know, whether it is funding by a government, governments, they're fickle, they change frequently, and that shifts the entire context in which we're working. And similarly, research funders. And there's a real issue there, I think, with research funders setting priorities for given topics that they want to look at and how those are identified and pursued. And again, that is a process that needs to be diversified and more inclusive to really be ensuring that the agenda that's being set is one that's responsive, as Violet was highlighting, to the needs of those that it ultimately aims to serve and to support.
Oh, sorry, I'm not muted. Eric, quick reflections, or you don't have to?
Very quickly, I don't want to repeat what was said, that is so to the point, but I think part of the question is about the meaningfulness of our research. Are we doing research that has an impact on people and that is sustainable in terms of its meaningfulness? And another question is about the durability of the research enterprise. And as Anna was pointing out, funding is always an issue in terms of being able to sustain in time or a research program or research orientation. But I think if we give more attention to how we choose our projects, why we research certain questions, for whom and with whom, and maybe adopt some of the more participatory research ethics practices or person-oriented research ethics practices involving co-production and engagement, there are better chances that our research will engage more people, will be seen by more people as being important, and maybe also increasing our chances of having a durable research agenda, and that we'll have the motivation ourselves, our colleagues, our students, to pursue a line of work that is meaningful. So I think there's part of the responsibility that befalls on us as researchers of not simply setting for an internationally established research agenda that is basically for everyone, but no one specifically. And to me, in my experience, what I've been doing in the last couple of years is giving an increasing amount of attention to acting locally, even though we try to think globally, to act locally in a way that what we do will not only respond to an international bioethics research agenda, but also local. Surprisingly, there's very little attention given to what a Canadian bioethics actually looks like, because we're highly influenced by more powerful research communities internationally. So even us, we have not really paid too much attention to this. And I think as individual researchers and our research teams, we need to give more thought to this and adopt practices that allow us to pursue this in a very practical way.
Wonderful. So this is undoubtedly going to be the last question directed to the three of you. We've got about 12 minutes left. So there are several questions, starting with Angelica Mkorongo. Thank you for that question, Angelica, about involving people with psychosocial disabilities in conducting the research. So rather than speaking about people with psychosocial disabilities as being the subjects of research, that was picked up in a slightly different way by Caesar Atwire. Thank you for that question, Caesar, who asked about the involvement of people living with, he calls it people living with vulnerabilities, presented on IRBs and included in decision making. And then Hannah Stewart and Bethan Burnside, hello and thanks, Hannah and Bethan, asked about the importance of people with lived experience, co-designing research, designing research, leading research, and speaking to these issues, with the observation that none of us have declared ourselves as being people who have lived experience of mental health conditions. And so I wonder if you want to speak to that. It intersects, for me, it intersects with an important question about advocacy and ethics, right? So advocacy and ethics and making sure that vulnerabilities are people living with vulnerabilities take a leading role in this research. So Violet, maybe Eric, you'll go first this time. Anna, maybe you'll go last, and Violet, you go in the middle. If you want to have some concluding thoughts about the importance of advocacy, leadership by people living with mental health conditions, and perhaps the way forward.
Well, I think this is one of the interesting ways forward. Engagement, maybe what people call advocacy, participation, representation. Again, reviewing the literature, there's a lot going on that can inspire us in this direction and give us the confidence that it can be done. I'll send also a link to an edited volume where we compiled a number of experiences of people engaging people with cognitive disabilities or cognitive impairments in research, research ethics board, researchers, co-researchers, and so on. And interestingly, just to come back to my opening statement, I think these are the kinds of concerns that we find very important from an ethical standpoint, but are not well represented by the mainstream research ethics agenda. So we also need to think about the kind of research ethics that we need. Research ethics that makes things better, concretely, and in a kind of a experientiable kind of a way, so to speak. Not only guidelines, but changing the experience of being in a research protocol. Ethically, I think that should be our measure in the end. Our outcomes should be the experience of our research participants. So to do that, I think engaging people directly is a very, very important, like unavoidable way of moving forward. I can only support that. Yeah.
Wonderful. I think Violet next. I forgot what sequence I assigned.
Thank you, Jantina. Just to echo Eric, I couldn't agree more. As you know, looking at the history of research was done on people. In fact, I avoid the word subject. It was done on subjects. Now we are seeing them more as a key, stakeholder in the research process. So we are seeing them as not just participants, as key stakeholders who are identify the priority areas. We engage them during the design. We engage them during implementation. They help us with the recruiting participants. They help us interpret the data we collect. They help us even with the feedback sessions in the communities and in advocacy that may need to be spurred out of that research. And you find sustainability actually with whatever it is that are deliverable that comes out of that work that needs to improve the lives of people. And that's the aim of research, really. We should be adding to the knowledge base, but also enhancing our lives across the globe holistically. So I cannot emphasize more, but the point is let's consider them key stakeholders in the research process and engage them from the word go. Over.
Wonderful. Anna?
A couple of final thoughts, hopefully, around this idea of kind of advocacy and leadership by those with mental health conditions. I was just reflecting as the others were talking on again the language that we use, and you know, similarly to Violet, I'm not a fan of the term subjects, but one of the terms that I particularly like, which is often used, is the idea of experts by experience. And actually, as researchers, we are experts by experience in the field of research, perhaps in the kind of methods and the approaches and the systems that sit behind that, and that can be complemented by experts by experience in other areas, including those with mental health conditions. You know, if I was going to conduct a study employing a method I wasn't familiar with, I would look for the expertise in somebody else. I don't understand why it would be any different when it comes to something like a lived experience of a mental health condition. I think there are challenges to this, and certainly from studies that I've been aware of that have been conducted here in Liverpool, looking to really embed these ideas of engagement and involvement and co-production, they're complicated and they are time-consuming and they are hard, because you are dealing with people and you are dealing with relationships and you are often dealing with power hierarchies in particular that underpin all of those. So I think there is probably work that still needs to be done in breaking down a lot of those barriers, and being able to think those through in ways that are, again, facilitatory. Coming back to the comments that we were making earlier about ethical review boards, we as researchers need to look for ways to facilitate engagement that is accessible and appropriate. And just a final point on this, actually reflecting on the GB, you know, the upcoming GFBR event that we have. And in fact, we really sought to include experts by experience, include groups representing those with mental health conditions on our planning committee, to try and think through actually how can we reach out, how can we be looking to engage people, you know, in that way. And it was a lot harder than we'd anticipated. A, to identify relevant groups, B, to engage them in those discussions. So I think that there are, I feel a bit like the pessimist on the panel, but there are, these things are, they're always challenging and never that straightforward. The sense that I get, however, from the comments, from the chat, from the discussion that we've had today, is there is a lot of optimism, and I think there's a lot of reason for that. And so I'm not suggesting that we shouldn't pursue these things, but that there are often tensions that arise sort of along the way that we need to be cognizant of, and need to be, you know, reflectively trying to anticipate and overcome in order to facilitate the development of the field more broadly.
Excellent. Thank you, Anna, and all panelists for those really thought-provoking remarks. There have been lots of encouragements in the chat and in the Q&As, applauding you all for your contributions. I think we've had a wonderful session. This is obviously not done and dusted. It's as I said, only number 2 of a series of webinars, followed by the online GFBR this year, which promises to be a really wonderful, dynamic and engaging event. We've spoken about many different things. Sassy has put it all really nicely, speaking about embeddedness, advocacy, being human, positionality, openness, a learning attitude, as Eric called it, priority setting, anticipating dilemmas, inclusion, and much more. So with that, I would like to remind you that the next seminar of this series happens on the 26th of October, and the details are available on the GFBR website. There have been many comments and suggestions for resources in the chat. I hope Adrienne will capture some of those and hopefully put them together, perhaps on the GFBR website. The video will be, or the recording of this session will be available in about 2 weeks on the GFBR website. And please do not hesitate, any of the listeners, do not hesitate to get in touch with any of us, I guess, if you would like to follow up. It seems to me that there's a need for some kind of community and broader discussions on some of these issues. In what I agree with Eric was the globalist audience for some of these discussions yet. So with that, thank you to everyone for your enthusiastic participation. Thank you to Adrian for your tireless working behind the scenes, and the wonderful panelists for all your enthusiasm.